everyone. It is our pleasure to welcome all of you today to this webinar, proudly hosted by Veiva Scientific. This platform brings together an esteemed panel of interventional cardiologists from across the country to share their clinical insights, personal approaches, and real-world experiences on the important topic of advanced balloon technologies for resistant and calcified lesions. We sincerely thank all of our distinguished panelists, moderator, and speakers for joining us here today and contributing their expertise to this academic exchange. To guide us through this evening session, we are honored to have Dr. N.K. Mahesh sir with us. Thank you, sir, for graciously taking on this role and steering this important discussion. Without any further delay, I now hand over this platform to our respected moderator, sir.
Thank you, Gauravi. Now we'll start with just the introduction of the expert panelists. First person I would like to introduce is Dr. Prakash Veer Parikh, a senior interventional cardiologist from G.R. Mehta Institute, and he's from Ahmedabad. He's got extensive experience in the diagnosis and management of complex coronary and structural heart disease, expert in high-risk PCI, acute ACS, advanced catheter-based therapies, recognized for clinical precision, ethical practice, and patient-centered approach to cardiovascular care. Welcome, sir. We have Dr. Sanjeev Roy, my good friend and great cardiologist. Dr. Sanjeev Roy is presently the director at the Department of Cardiology, C.K. Birla Hospital, or Rukmini Birla Hospital, Jaipur. His expertise is in coronary angioplasties, predominantly through radial access with plaque modification, RA, ECLA, ECLA, intravascular lithotripsy, physiological assessment, image-guided OCT, and an excellent speaker and very well-read person. You got to be careful when you are discussing with him. He will put it on. I hope he's still there. Dr. Karthik Vasudevan, my savior, who saved my backside in the last meeting. Thank you so much. And he's from Bangalore, Manipal. His areas of specialization encompass the interventional cardiology, heart failure and heart transplant, and left ventricular assist device. He has developed a keen interest in performing complex coronary interventions, including angioplasties guided by advanced imaging techniques. So these are the main people who will be in the expert panel. Now I would request Dr. Parikh. Is he there, Dr. Parikh? No. Okay. Dr. Sanjeev Roy, to introduce Dr. Sahu. Do you have Sahu's details with you?
No, I request you to do that because I don't have the details.
Dr. P.K. Sahu is very famous. He's an excellent cardiologist. He was with the CIC, CSI, NIC, organized fabulous conferences. And he has been 37 years of experience in the field of cardiovascular health. He's got prestigious fellow of prestigious in FRCP from both London and Glasgow, as well as FACC. Otherwise, he's got fellowships from Society for FSCI and FSCI USA, FESC, and FICC, that is Indian College of Cardiology. So he's got all the fellowships, currently serving as Senior Consultant Cardiologist and Director of Interventional Cardiology. Dr. Sahu is also an Adjunct Associate Professor, where he imparts knowledge to the next generation of cardiologists. Then I have my good friend, Dr. Shelvamani, who actually requires no introduction. Slim, handsome, and well-built, and always has a following wherever he goes. He's currently associated with the Meenakshi Mission Hospital and Research Center. He has performed more than 20,000 PCIs, more than 2,500 OCT procedures with 4,000 plus OCT pullbacks and 1,100 plus carotid stenting, 1,000 BMVs, and more than 1,000 BVS implantations in the last 20 years of experience. Hame doob jana chahiye. Okay. Selvamani, that was just too good. So then we have the speakers. Now I will request Dr. Sanjeev to request the first speaker, that is Dr. Raghu, to go with the first case.
Yeah, good evening, everybody. Is Raghu on there?
He's there.
Yeah.
I'm there.
Yeah, so I would request Dr. Raghu to kindly present his case.
Yeah. Thank you. Today, I think we can see the screen now.
Almost.
Yeah. Okay.
You're on.
Okay. Okay. So, good evening, friends. Today, I would be presenting a patient where this is a symposium on the Apata balloon. So, I thought that I will show one of the cases of Apata, which I did some time ago, about 2-3 months ago. So this is a gentleman who is a 75-year-old gentleman. I don't know, it's not moving. Okay, yeah. So he is a 75-year-old gentleman. I got his bypass surgery done in 2012. He has diabetes, hypertension, and his ECG is showing lateral wall ischemia. And ejection fraction is normal, and he presented with chest pain of recent onset for about 5 days or 7 days before the procedure what we did. So he had grafts to the LAD and the the circumflex graft got completely blocked. The lima to LAD is functioning well, and this is the right coronary artery which is non-dominant. You can see the right is completely non-dominant, and you can see that the left main has a tight stenosis distally, and then there is one more stenosis in the circumflex in this area, and in this, and then one more stenosis in the LPDA and the third OM junction. So these are the target stenosis for us in this patient, and you can see that this is about 13-14-year-old bypass surgery. And then you can see that the LAD, this is a functional occlusion of the LAD, and the graft to the LAD, which was a lima to the LAD, is working. And we can see in the levo-cranial projection that you have got a very tight stenosis, which is going to the PDA and also to the OM. So there is an extensive disease from very long disease segment, and starting right with a huge amount of calcium at the junction of the left main and the LAD and the circumflex. And he has a very significant long segment stenosis, as you can see in the levo-cranial projection. And we can see that there is a PDA and a OM stenosis. So he has a single vessel dominant left circumflex disease with 3 marginals coming 1, 2, and 3 with a PDA stenosis. So that puts us into a scenario where I wanted to do a PCI for this case. And putting a very long stent in this scenario, I felt it might not be the right approach for him. So I planned an angioplasty and a stent as a backup, but a drug-coated balloon as the first strategy. So there was some challenge in passing the guide catheter because of the tortuosity at the subclavian brachiocephalic junction. And we got it down finally with a inchworming technique with a 7 French EBU. We got it down because we took a 7 French EBU because we wanted to do a rotablation. And personally, whenever I do a rotablation, I usually take a 7 French guide catheter. So the first thing what we did was we passed a fielder FC and then exchanged with a rota wire. And then we are trying to pass the rota burr of about 1.5 here. And we did a rotablation here, followed by as we remember, he had a distal stenosis also. So we did a rota for both the locations. Then this was followed by a serial balloon dilatation with a 1.5 and a 2.5 mm balloons. As you can see, we placed 2 wires, one in the LPDA and other in the OM to protect them. I did not venture to put more wires for saving the branches, but the distal branches appeared important to me. Then comes I did use if you can remember, we used a 2.5 balloon. So later on, we used an apata balloon to, after the rota, after the balloon dilatation, I used an apata balloon, which is a 3O balloon, to dilate the entire segment of the vessel. So the challenge was the distal LPDA. If you see, we were having a wire, but I removed it because the vessel looked very diffusely diseased. So I wanted to keep the procedure simpler. So after the calcium modification with the rotablation with a balloon, I gradually upsized the balloon to a 3 mm apata. So that brings us to the IVUS image. You can see the IVUS image after the apata. If you can see here, I will make it run little faster. So you can see at the ostium of the circumflex ostium, you have a large amount of calcium, and that calcium, you can see that the entire calcium got broken off after there is a lot of plaque, the calcium rupture after we did the balloon dilatation with the aperta. So with the rotational atherectomy followed by an aperta balloon, we could get an excellent calcium modification at the ostium of the circumflex, where you can see here, you can see the calcium in the LAD. Similarly, you had a calcium in the circumflex ostium, which could be broken with the aperta after the rotational atherectomy. So I did use the aperta as an adjunctive device. And you can see the IVUS images where we got a very good luminal gain. And you can see the control angio. You can see there is a good result in the entire segment. Then following that, this is the angiography movie frame. You can see all the branches, 1, 2, 3, all the 3 branches were nicely filling. And what I did was, you can see that I was putting a guide extension catheter. So this guide extension catheter we did use because for all the drug-coated balloons, especially if I'm using a very long drug-coated balloon, this is another thing which I follow is I use a guide extension catheter routinely so that my in and out of the balloon, if you can see here, I used a 40 millimeter 3/0 40 millimeter balloon, and proximally I used a 3.5 into 30 millimeter balloon. Those balloons, especially in a post bypass surgery scenario, we need an additional extra backup. That is why I used a guide extension catheter, and I used 2 drug-coated balloons for the entire circumflex, entire extent. And this is the final control angio, as we can see here, that the left main and the circumflex ostial is good, and you had a distal stenosis. Actually, here from here on, stenosis is good. And as you can see here, the PDA was quite small and diffusely diseased. I did not want to try too much into the PDA, but you can see the last OM is also filling, and all the 3 grafts are there. All the 3 OMs are there. So I would like to share my take-home messages. Post-bypass interventions are quite challenging because of the calcium, diffuse disease, and complex tortuosity. Here, for the intraluminal calcium, we used a rotational atherectomy, and to get the maximal luminal gain and to break the calcium outside, we used an aperta NS balloon. And for those patients where I use a long drug-coated balloon, I usually have a low threshold to use the guide extension catheter. This aperta balloon, I find it unique in my unique because for almost I would use about 70 to 80% of my patients a NS balloon, where I use a high pressure, short length, and final balloon dilatation prior to DCB is my final aperta before DCB is the way how I do it in my routine practice. These are the small tips which I wanted to share with all my attendees. Thank you.
Thank you. Next will be Dr. Selvamani and Dr. Sahu to chair that presentation. In the meantime, Dr. Sanjeev, you can have a discussion with Raghu. We got 3 minutes left. Sanjeev, you there? Okay. Sanjeev is missing. So, Dr. Raghu, fabulous case, very well presented. I'm a big fan of their guideliner, big fan. So it has saved me so many times, it's unbelievable. I think aperta is very good. Sanjeev, your views.
Yeah, so I just wanted to know from Raghu, I mean, of all the cutting balloons available, what made you select aperta? I mean, what are the features for the audience they would like?
I think, Dr. Sanjeev, the first thing why I use the first thing is why I choose an aperta over other the scoring balloons or the cutting balloons is because the crossing profile is much more smaller compared to the other balloons. That's number one. Number two is once we inflate the balloon, I can go up to 14, 16 atmospheres without any problem because this is a non-compliant balloon. That is the second thing. The third thing is, once in a while, I keep seeing, and I did not have a personal experience, but I did see quite a few presentations from operators who use a routine blade-based or a metal-based cutting balloons, where there was some coronary perforation following when they did a high-pressure inflation. So that's the one third reason which I prefer to use an aperta over the other scoring balloons which we have in our market. And the other thing is, especially if somebody is working in a low resource setting, then maybe the reusability of an aperta is much higher. You can rewrap the balloon and then use it multiple times. And then there is a very excellent green color rewrapping tool, which is there for the aperta balloon, which I encourage all of you to use. So that they will be able to use that balloon if needed for a reuse or something if they are working in a cost-constrained environment. So these are the reasons why you use an Apata compared to the other scenarios.
The other thing I want to know, like, when you're using an Apata or any other cutting balloon, are there issues of the size of the balloon and the size of the guide extension catheter that you choose? Because many of the, larger cutting balloon are
Yes.
not compatible with particularly tapered tip guide extension catheter.
Yeah, the other thing is very important. I forgot. We have cutting aperture up to 4 millimeter, which I use routinely. A 4 millimeter aperture through the guide extension catheter. It goes through that. It goes through a 6 French system also. I took a 7 French system for this patient because I was using a rotational atherectomy. I was not sure whether I wanted to upgrade the burr or something. That's why, as a precautionary measure, I used a 7 French. But for a 6 French also, we can take a 4 aperture without any challenge. Even a gas depot also we can use that.
I think we will just have a discussion once more once we come to a similar case. Dr. Sahu and Dr. Shelvamani will present. Dr. Sahu, please conduct that presentation.
So I will start my sharing. Okay.
Yeah, please do that.
Are you seeing my screen?
Yes, we are able to see you.
Okay. Okay, just hold on. You are able to see? Are you seeing my screen, please?
Yeah, screen is
Yes,
seen.
Shelvamani, very good. Put it on slideshow.
Yeah, slides.
Let me go back. Yeah.
Perfect, we are on.
Yeah, fine. So thank you so much for calling me here with among all our seniors and friends here. And anyhow, Mahesh sir, you got my CV probably that is 10 years old. And somewhere they have got that and given it to you. Just
Apologies. Money, you're in trouble.
Okay, fine. I have been asked to talk on this cutting and scoring balloons in practice, how we place it in presence of other debulking devices. See, what debulking devices we have in special balloons are basically, we are all familiar. It's rota, orbital, laser, IVL, cutting, scoring, and high pressure balloons. So how do you place all these things in modifying the plaque as well as the calcium predominantly which we are worried today? So there is no question. Only first, probably the only one and only indication for atherectomy for me as of today is probably it's a non-crossable lesion or a non-dilatable lesion, probably most of the time. Basically, we don't have any other options other than atherectomy in a non-crossable lesion. Either you can use a rota, a laser, or orbital also to cross a lesion which is non-crossable by a balloon or with a microcatheter. And high pressure NC and IVL or probably our scoring balloons are also a very good option in patients in where the balloon crosses but it is a non-dilatable lesion. When your routine NC balloon is not expanding, probably these are the options that we have today. In all other lesions, probably our balloon-based approach is very, very good. And many times, even after this atherectomy, we need this combination, like whatever Raghu showed. Similarly, we have so many cases where we combine all the special balloons along with atherectomy to improve the outcome. And before that, imaging, especially OCT IVUS, is a very important ideal move when you treat all these complex cases, so that you can treat how exactly and what is the best way to treat is very, very important. Now, the problem with calcium is we have a lot of cases because of age and then so many reasons. Compared to 20 years back, today I am getting a lot of patients with severe calcium, and we have started treating all these patients. Previously, many times we were unable to treat it. They used to go for surgery or put them on medical management. And many times we have had only an NC balloon where we couldn't dilate and just left it like that. These were the scenarios probably 20 years back or 25 years back when I started around 2000, where very little options were available. But today we have superb options, and let us see how to go there. See, why it is important is, if it's a simple lesion, you go by stent. If it's a very complex lesion, probably you go by rotational atherectomy or orbital or laser or IVL. And this is between these two. One is simple, another is complex. In between, there is a niche link that what we have been concentrating today, where if you use all this rotational atherectomy or IVL, it is going to be over treatment. If you are just going to use a small NC balloon, probably under treatment, you are going to have under expansion. So your specialized balloons, especially whatever we are going to talk today, the cutting balloon, the scoring balloon, and all these balloons come here. It is probably the middle ground where it is important, or after using this atherectomy, probably for better results, we use it today. So that is the current position. So why does normal NC balloon fail? Because it is basically because of compliance mismatch. The calcium is a very thick material, and these semi-compliant balloons are very soft. So what happens, whenever they dilate the balloon, it stretches at the normal segment where the vessels are normal, but the calcium is just left over. So when there is a difference in compliance, what happens is you get dog boning. That is, wherever the severe calcium ring is there, the balloon does not expand. But in a normal segment, it expands and produces dog boning, and it produces dissection in healthy edges, elastic recoil, and failure to fracture the calcium link. So these are the reasons why a normal NC balloon fails. To overcome this, today we have beautiful balloons like cutting balloon and scoring balloons, especially aperta. Why? What is the main principle is, see, the pressure is forced by area. So in a small area, if you apply some force, the pressure is very high. If you apply the same force over a large area, the pressure is less. So basically, that is the principle here. All these special balloons like cutting as well as the scoring balloons, they have blades or this wires or this nylon rings in the aperta. What they do is they produce controlled dissection, because when you inflate at probably a 25-30 atmosphere, the pressure applied on the vessel is more than when you just apply it with an NC balloon. So it produces controlled dissection, and probably when you dilate like that, the calcium ring breaks and you're able to expand the vessel. And very, very important is the melon seeding effect, especially in a fibrotic lesion as well as in severe calcium or in a nodular lesion. When you keep this balloon, it just avoids this slippage. So that is a very important point why these new modified balloons are available or needed. Generally, what are these balloons we have? Wolverine cutting balloon, where they have 3 blades. Angiosculp, we are no more using, probably it's not in routine use. NSC alpha was there, now we have NSC aperta, which I will just highlight a little bit. So it has a beautiful 3 triangular nylon elements. And of course, Coreflex is also, it has 2 dual wires. It has only 2 wires. It is something like you put 2 extra wires and put a NC balloon and dilate. That is equivalent to a Coreflex, and of course Naviscore. So these are the modified balloons that we have today in contemporary use. This aperta is a next generation scoring balloon, there is no doubt at all. See, basically it is integrated by these 3 elements, and but this height of this element is probably, this is the inches, 0.39 millimeter thick, and it is actually not an NC balloon, it is called as low compliance balloon. So basically, compliance is less, but it is again something like a NC balloon. It's a low compliant balloon, and RPB goes up to 24 atmospheres here. And very important is crossing profile in all these lesions. So when you compare these 3 commonly used balloons, if it is a very thin area where you are finding it difficult to track, probably the crossing profile is very good. And compared to cutting balloon, aperta is good. And then finally the Wolverine or the cutting balloon. So this is very important you remember in your practice. So when you select these devices here. So then of course, compared to other scoring balloons where they have only 2 wires, it forms a triangle like this, forming these three thick elements. So it holds to the calcium or to the nodule, and it does not allow the balloon to move. So my experience, what I felt is, once you take this aperta and dilate, you get excellent expansion in calcium, even in eccentric, circumflex calcium. And the problem when I use cutting balloon is, most of the time when I use a cutting balloon, I need to take one more NC balloon and dilate to get a good balloon. But here, the aperta works as both. It works as an high pressure NC balloon as well as a scoring balloon, which has three nylon triangles where you get excellent expansions in this case. And especially in ISR also, I have an experience where it expands very well. We are all familiar with Wolverine. It has three longitudinal, 3 to 4 depending on the balloon size, and probably that is how it is placed. And these blades are engaged instantly, and it's very good for ostial and instant restenosis. And this alpha, probably it is been modified into aperta, which I already told you. It is excellent trackability with good results. And Scoreflex has extra 2 wires. But only advantage is probably it is slightly more trackable compared to cutting and then other balloons here. When you look at the trials, how it happened. So when it was in 2018, we have this pre-pair calcific trials. So they use this, they compare it with rotational atherectomy with modifiable balloons. Basically, at that time, whatever cutting balloon we had and the scoring balloons. And then what they found is, they included all cases, and they found out in uncrossable, undilatable lesion, there is no doubt we'll have to take rota. But once the balloon cross, the outcomes are similar whether you use rota or not. So that is the principle which we have been practicing from so many years, and that has come out in the results also today. And ISAR Calc study, they compared OPN with scoring balloon, and probably OPN having a high pressure, probably it achieved a little bit more lumen. But today with aperta, I don't think there is any issue. It expands extremely well with good lumen expansion. And very important recent 2025 study, what we call the shortcut study. That is, they compared cutting balloon versus intravascular lithotripsy. So this is a landmark trial where probably it saves a lot of patients with the cost also. And one more trial is Victory trial. They compared IVL with OPN. Both are important trials in this modern cardiac practice today. So what they designed is they compared cutting balloon and IVL in standard severely calcified lesion, and they were treated with this balloons there. So finally what they found out is this cutting balloon or balloon-based technology, apart from other than IVL, is equivalent, or probably it's non-inferior to IVL. So whether you use IVL or you use this cutting balloons, the overall outcome is non-inferior. So it is probably there's no difference in perforation, dissection and maze at 30 days. So that is a very important result, which is a very new result, which we have practiced, and that is what they have shown in the study. The advantage of this study is probably you cut a lot of cost in using the IVL balloon. A Victory trial also said that probably OPN is also equally good or non-inferior to IVL. Eclipse trial is one where we found out that routine atherectomy may not be so useful. Here, what they did is they removed non-crossable and non-dilatable cases. So this were removed from the study. When they compared that with conventional balloon, they said probably there is no advantage in using orbital. So that is what we have been also doing for so many years. And very, very important outcome is when you use image guidance, whatever modality of device you use, the results are excellent. The problem arises when you don't use imaging, your selection of device, and even if your selection is good, where to treat in the vessel. Usually it's going to be a long lesion. You don't know the segmental mapping of the vessel. So you treat it at long places and land in trouble. So imaging is very, very important tool in today's practice. And of course, you know OCT calcium scoring. And today algorithm, what we do is you assess crossability. if the wire or balloon crosses, then there is no question at all. If the balloon or wire doesn't cross, then you go for orbital, laser or rota. Any one of these can be tried there. And don't try to push scoring balloons, cutting balloons across the lesion. It can just cause jamming there. If it is not going, probably you can switch over to either laser, orbital or atherectomy. And after the balloon crosses,
Elomani, you got 1 minute.
Yeah, you dilate. You see that if it is dilatable, probably you dilate. If you are unable to dilate, probably you can go to other high pressure balloons, or you go for rotational atherectomy or orbital you can do. And once your balloon is there, probably you go for all the scoring balloons. So instant restenosis is also very good, where you can also use this cutting balloons. And this is how in bifurcations also in osteal lesion, using a scoring balloon is very, very good. Calcific nodule scoring balloons are excellent in this profile. So with this, since my time is running out, combination therapy is also very good. I have a series of 10-15 cases to show, but I'll show you one case where you look at this. We did it in around 2018. After that, we have been doing regularly so many cases. So this is one of the classical thing which we have been following. See, this is a case here, which is a severely calcified LAD, and there is a very tight lesion where we had difficulty in crossing the balloon. So then once the balloon does not cross, what option we have is only rota. So once you do a rota, you do an imaging. So once you do the imaging, you will know exactly what is the vessel size, what are the amount of calcium, where it is. Depending on that, you decide how you are going to treat it. So once you do this, you see the amount. It is a concentric calcium here, and after that we have put a balloon there. Balloon dilatation, you see here, we have put a 2 mm scoring balloon and then 3 mm scoring balloon depending on the tracking, and finally a 3 NC. You see the calcium here, concentric calcium, and you see the effect of rota, and you see some calcium fractures. And after that, what I have done is we have put a 1:1 balloon. So once you put a balloon, in spite of doing this, you see here it's a significant dog boning effect. So if this happens, what options do we have? It was in 2018. So we had very little options at that time. So we took a high pressure balloon, but I think OPN was available at that time. Took a high pressure balloon, dilated this, and once you dilate, you see that amount of fracture you see in the image. Look at the lumen gain, and once you do that, you see this is what we have here. And so excellent expansion. And then of course there is no doubt at all, you go to the with NC balloon dilatation, you stent and you decide on the expansion, you get excellent results. So this is the final result. So we have used all these devices, cutting balloon, scoring balloon, OPN, orbital, step by step. So that is what is recommended. And to conclude, we have a lot of cases which I will just skip off. We have use of laser, and then how to use in calcified lesion. Since my time is out, I'll go to the last slide probably and then conclude. So these are all ISR cases, and then unexpandable case in a calcified lesion. So with all this, we'll just skip. Yeah. So what I generally recommend is, imaging is very, very mandatory, and respect non-crossable and non-dilatable lesion. And then probably whenever the balloon cross, make use of the shortcut trial. So use a scoring balloon or a cutting balloon. If it expands, that is the first line preparation, expansion, there is no doubt it is very safe, and then you can go ahead and stent. If you are unable to expand with the scoring balloon or cutting balloon, probably you go for other devices like orbital or laser and make use of it. And if there is certain osteal locations, probably you can use scoring balloons or Wolverine balloon. In laser, osteal lesions are extremely good, and ISR, a laser and scoring balloons are excellent. And then of course for tortuosity, probably Scoreflex and Aperta is a good option. And calcific nodule, Aperta is a very good tool, It holds the calcific nodule perfectly and results are very good. Almost 3/4 of calcific nodule can be treated with aperta balloon. If it is not yielding to aperta balloon, then probably go for orbital or something. That is what is our approach if the balloon crosses. And escalation logically is the best way. So step by step, instead of you see a calcium looking at the angio directly taking an orbital, today does not apply. So the best way is you escalate slowly, you try with this balloon. If it is not yielding, especially aperta, and then probably you can switch over to other atherectomy device. I think I'll stop here. I've crossed my time. Thank you so much for the opportunity.
Thank you, Dr. Shalomani. Dr. Sahu, your 1 minute comment, please. We are a little short of time.
Fact, good cases, but yes, aperta is very useful because the best part is that we can go to very high pressures with this balloon. That's the beauty of this balloon, unlike other cutting balloons or the Wolverine or the scoring balloons. And yes, for osteal lesions, this is a very good device where we are afraid to do rota or we are afraid to do an orbital. In fact, I have a good experience with aperta, especially osteal lesions or lesions which are not yielding to the standard NC or the OPN balloons also.
Fabulous. Now, I would request Dr. Arun Kochar to share your screen. In the meantime, Dr. Raghu, are you still there?
Yes, I'm there.
Okay, the question is for you from one of the audience. How good is DEB in diffusely calcified coronary lesions? DEB doesn't work much in a calcified and thrombotic lesions. Is that right?
I think if you this patient normally for a very calcified short segment stenosis, yes, I try to put a stent. But if it is a very long, the entire length, I don't want to give a full metal jacket to a circumflex. And in my observation, in the initial set, we had done about 110 DCBs patients and 128 lesions, but we had 3 restenosis. So it's a fairly good tool. But I think the most important is break the complete, make the bed very good. Like in our case, we did it for the ostium, a good aperta, and the whole length with the rotational atherectomy and aperta all through. So the sequential, gentle, making the vessel too good size, and then doing the DCB, I think it works well.
Thank you. The second question is from Dr. Anu 1386. I presume that is 1st March 1986. That question has been adequately answered by Dr. Shalvamani. The question is about the NC, what is the 1:1 balloon dilatation, the sequence of rota, IVL, etc. I think Dr. Shalvamani has covered that extremely well. Now, if we have Dr. Arun Kochar is there.
Can I answer that? The thrombotic lesion and
thrombotic lesion. Please go ahead.
With the DEB, see today the interest of DEB has increased, and we have so few evidence. Like today, even in acute MI, in a thrombotic lesion, even in a major vessel, that is large vessels. I'm not talking about small vessels. Even in large vessels, in a thrombotic lesion, there is a study called Regenovate study, where they have found out it is equivalent to a stent there. So, and similarly for calcified lesions also, in that solution trial, they have shown that it works well, even in larger vessels. So, but our thinking we have been using for a long time at distal vessel and side branches. Today we have some evidence to say even in large vessels, thrombotic lesions, de novo DEB, that is for a de novo vessel, DEB is also a good option. And especially where Raghu, the main key in DEB is probably the preparation. You prepare the bed well, make sure the lumen is well expanded, and Antonio Colombo says you do FFR also. Make sure if FFR is negative, and then put a DEB, probably your results will be equivalent to stent.
Dr. Karthik, your views?
Used where? Aperta?
So he's talking about DEB.
DEB extensive. Now I have almost so many. Most of the multivessel angioplasties, 1 or 2 DEBs will be there. It's very common now. I'm using and as Salvamani was telling, it's very important. If you're doing DEB, you image the vessel and use a very good lesion preparation, whatever it takes, rota, then cutting balloon, scoring balloon, and make sure you get a good expansion, and you should get cuts, good cuts and dissections. Only then the depth will be very useful.
Yeah.
And once you get a good lesion preparation, then I think you can go and use the depth. And Raghu's case was very good.
Thank you.
And used large vessel is used too long depth. It's a fantastic case that was.
So, Dr. Parikh, I will request you to conduct this case, which is going to be presented by Dr. Arun Kocha. Dr. Arun Kocha is a consultant interventional cardiologist from Fortis Hospital, Mohali. Dr. Kocha, the stage is yours. Dr. Parikh, you may please conclude, opine and conclude the session on this particular case. Thank you.
Okay. Yeah. Yeah, please start your case, please, Dr. Arun.
Gauravi, are we on?
I hope my screen is visible. Actually, I'm going to share my screen on behalf of
Screen.
Dr. Kocher, sir.
Yeah. Dr. Kocha can start. We can see your screen.
Sir, I think he has been disconnected, so we'll just wait a minute for him to rejoin.
Or we can go to Dr. Sahu and come back to him. Yeah, we are moving on. Dr. Sahu, please present the case. Dr. Parikh, you are still in charge.
Yes.
Let's go to Dr. Sahu first, then we'll come back to Kocher.
Sure.
Dr. Sahu, are you there? Oh,
No, I'm there.
please start.
Just let me share my screen.
Thank you.
Just a minute. I'm having some issues over here.
Dr. Sahu and issues unheard of.
Yeah.
How you are looking tired? Must have been a long, busy day.
No. I've just asked someone to carry on with the lab work. Is the screen visible?
No,
Yeah. No, we can see you, not your
screen not
presentation.
share screen.
In fact, the screen is not visible.
Just press that
I'll share again.
share button.
Yes. Now it should be.
Yes, you're coming on.
Good.
Bang on.
Okay.
Yes. Go
All
on to
right.
speak to. Yes, excellent. Please go ahead.
So basically, I have to speak on the role of no shoulder balloon in a complex angioplasty. It will be basically one of a case that I'll show. So I'll directly go to the case. It is a 62-year-old male, non-diabetic, non-hypertensive, has a very strong family history of coronary artery disease, had an inferior MI, and in fact underwent an angio. This was done in another center. The LMC had a distal 70% lesion. The ostial LAD has a 80% lesion. The diagonal has a 70 to 80% lesion. Sorry, the LCX had distal some lesion, minor plaques, and the RCA was 100%. So in that center, they just did a primary PCI to RCA. And then this patient came to us for a second stage PCI, which was posted 1 month, because this gentleman was not willing for a CABG. This gentleman was very finicky, especially his children, because they stay abroad. So they were not telling whether a PTCA can be done. Well, we agreed. And this is the RCA, which has already undergone a primary PCI a month back. So it was flowing well. So once we go to the left system, what you see in the left system is that the distal LMCA has got some plaque. Then the ostial LAD and also the proximal LAD has also some plaque. And there is a diagonal, which is a fairly big size single diagonal that is present in the full, this thing that is left artery, which is also has some disease. So we had a plan that we would be planning for a single stent strategy and possibly do a DB for the diagonal. And that is what we did. Before that, I wanted to image to plan my strategy. If you see, this is a large leftment which tapers on to the proximal LAD, which is diseased. Sir, yes, there is some disease, but angiographically doesn't look very significant. So I thought I'll escape by doing a single stent strategy from the healthy part of the leftment till the healthy part of the LAD. Now, if you see the IVUS, the leftment was totally clear. There was absolutely no plaque till at least the mid leftment. And when we go to this thing that is the LAD, you can see that there was almost a very tight stenosis of 80% plaque burden that you can see. And once we went to this thing that is the bifurcation, You can see also this osteum does not have much of plaque at church. Most of the plaque is in the LAD, this thing that is territory. So that was my strategy, that just to go for a single stent and come out, make the procedure as simple as possible. Yes, for the diagonal, I had planned a DB because there was some osteal disease and I was expecting that I would pinch this problem, this diagonal. Now, this is what I started off with. I did a pre-dilatation of this thing diagonal and finally used a 2.525 solution to this thing that is diagonal. And that is where I thought that my diagonal job is over. And then I went for the pre-dilatation of the LAD till the left vent. So this was bed preparation was done. And then a single stent was taken, starting from, you can see from the mid part or almost nearly the ostium. This was a 4.5, which was just planned to be because this was almost a 3.8 LAD. And that is what I planned, a single stent strategy. Of course, I had not kept a wire in this thing, that is SURF. That was a mistake that was on my part. I was a little bit overconfident. And this is a stent being deployed. And after the stent has been deployed, in fact, there was a wire, yes, a wire was put and the stent was deployed. And this was the final result post deployment. But surprising as expected, what happened, then I did a post this thing dilatation of the port. Normally what I do, I go from the proximal to the distal part, the port in the proximal, then the mid, and then I go to the distal part. The reason with that, it will prevent stent deformation. And of course, if the proximal part doesn't get deformed, you have a very good result distally. So many people have also the habit of doing it from the distal to the proximal part. This is what I prefer, from the proximal to the distal. First, try to tack up the proximal part so that the stent doesn't get deformed. Now, why port is important? You are all aware of it, that once there is a bifurcation, one has to do this in a single stent techniques, and the primary stent should be sized according to the distal main vessel diameter. And post dilatation or kissing balloon inflations are required to optimize the proximal main vessel, and this diagram illustrates the picture very well. And of course, what is the difference between a pot balloon and a regular balloon? You see, the regular balloon has got a shoulder. I mean, supposing you are putting a balloon over here, it has got a shoulder with a long balloon shoulder. But in the pot balloon, there's an ultra short shoulder. Not that it doesn't have a shoulder, it does have a shoulder, which is very ultra short. And the best part is that you can keep your marker just exactly at the stent site. There's hardly any this thing that is overhanging of the balloon. The best part is why, if you use a pot balloon, the chances of edge dissection are quite minimal, because you see, this is something that you're worried about. If you keep your pot balloon just exactly at this thing that is a proximal part, these things will not take place. But whereas you take a balloon with a long shoulder, very lot of chances that you go to high pressure dilatation or do a pot with that, definitely there might be an edge dissection. And I have seen quite a number of cases where I had to put a very bad, nasty dissection, and I had to put another stent. Now, these are the expected benefits. You achieve full apposition of the stent proximal to the bifurcation and to correct under expansion. Preclude any unintended wire into the behind the struts, because it is already, when you do it from the proximal part, you expand it properly and you doesn't see whenever side branch doesn't take place. Facilitate further access to the side branch with any other device. And finally, correct the final stent deformation following kissing balloon or side branch dilatation, report. In fact, what I do, I take a single pot balloon and try to do it. I don't take multiple balloons in this case. Now, what we did was that this is an angio post pot. You can see very nicely that the left vent to the LAD has got a good result. But surprisingly, what you see at the SURF ostium, it looked like there was a plaque shift. We're not sure. And so we thought that something needs to be done here. And then I thought the best thing would be to just push in an IVUS catheter and see what's going on. And this is what the IVUS showed. It was intramural hematoma. This was a large intramural hematoma which was impinging into the SURF, and definitely the lumen was somewhat compromised, not totally, but definitely I couldn't have left it. So I thought I'll use a cutting balloon over here. But anyway, I went straight forward with a dilatation for the SURF ostium, and an aperta was used over here. And after the aperta, I did a kissing balloon, hoping that I wouldn't use a stent. I just wanted to debulk that intramural hematoma and did a kissing balloon, finally hoping that I wouldn't, but the results were not good. So finally, I had to take this thing stent and then had to put a stent. But this is after the first initial kissing balloon dilatation, after the aperta of the side branch. The results were not very good. And what then I had to do was do a crossover stenting with a 3.5 16 synergy, and finally do a kissing balloon and do this thing. That was the final result. So this is what the final angio, which it shows. So the circ had also to be stented because of the intramural hematoma. We couldn't leave it there. Now, this was the final result pre and this was post. Let us see what the IVUS shows. The IVUS showed that the circ area is very good, only 39% plaque. You can see how well it is opened up. The LED also was well expanded, and you can see the stent is to the tune of 11.73 with 37% plaque burden. And this was the LED, which also shows that it has expanded. Shows in fact the left main. This was the left main, which was almost 18.34, and we didn't have any edge dissection. This was the proximal part of the left main stent with only 27% plaque burden. So this was the final result you see in the cranial view and in the caudal view. And my take-home message would be how POT helps. Definitely precise and controlled dilatation at high pressures and has got some clinical advantages. Now, why we call it as a precise and controlled dilatation? Because you see there's a minimal shoulder, the dog bone effect doesn't take place, uniform lesion expansion takes place. It is effective in calcified and resistant coronary lesions, optimized stents expansion and apposition, useful for lesion preparation before stenting, but normally I don't use this thing that is a pot for lesion preparation. I can keep it for my final dilatation. Clinical advantages: reduce edge dissections. This is very, very important. And vessel trauma, because in many cases we've seen we use this balloons with shoulder, and there is a lot of edge dissection times. Maintains a fixed diameter, accurate vessel sizing, better procedural precision in bifurcation ISR lesions, and high burst pressure. It has, you can go up to 12 is a nominal. You can go to very high pressures also, and suitable for complex PCI. So this was my final take-home message: where to use a pot and see, and how we can safely do it so that the expansion is good, the position is good. As you have seen in this case, this was quite a simple case, excepting for the reason that the intramural hematoma occurred on the side of this thing that is circ. So we had to go with a crossover stenting with another stent to the circ. Thank you very much for the patient hearing.
Dr. Parikh, your views, please. You're muted.
Dr. Parikh, you are muted here.
Yes.
Okay. We are
No,
not
not
able
yet.
to hear
You're not
you.
audible for. Although you're unmuted, you're still not audible.
Okay.
Some audio issues, I think.
Okay, Sahu sir, how often
Yes.
have you used aperta to break a hematoma? Like
See,
especially in this
aperta, I
case,
have
it was a
for
very good
apertas. How
case.
often they use for? Excuse me.
But treating the this hematomas, no? Whenever you have an
See,
hematoma,
normal.
conventionally it has been advised you use a cutting balloon or put a stent.
Yes,
It
exactly. In
was
fact,
very
this is
good
the
for
only
us.
case,
Yes.
because this was the case which aperta was given to me as a trial basis. So I wanted to see how the aperta does, because it is a sort of a, I thought it would work actually, but the results were not good. Of course, it is not for this intramural hematoma. As you're right, Ulverin would have done a better job. I fully
Can you
agree.
do an imaging after you put the this aperta in
Aperta.
the aperta at the hematoma? Could you demonstrate what has happened?
In fact, the patient started having angina that time, and I didn't do an imaging. I straightforward went with the stent, and I wanted to finish it off as fast as possible. That's the whole
Fine,
thing.
fine.
Dr. Parikh, can you try once again whether you're audible?
This regarding this pot balloon,
Yes.
we are using it extensively and it is very, very useful, especially
Yes.
for a single stent when you are doing a final pot or any pot, wherever it is. How do you, did you face any issues when you are doing the ostial left main with this pot? Did you have
See,
any
the
issues?
problem with the ostial left main is I had one terrible problem with it. So when I did the ostial left main, the pot just jumped outside.
Yes.
after it jumped outside, in fact, the full wire also came outside.
Is
And
not
then what I
audible.
did, I actually rewired it. Unfortunately, this thing wire went inside the strut, and inside the strut it became abdominal. And then nicely, my other balloons went, and then I did a part. A part of the whole stent was hanging into the left outside the left main. Then I had to put another stand to complete the job. That was the bitter experience I had with pot, where these balloons are very small. This thing has a very no shoulder, and it has a chance, if it is a very fibrotic lesion, it might just jump out.
Jump out.
So yes.
Yeah.
So one has to be very careful, and after that, the practice of going very slow dilatation. That is what I do. I don't go. This, of course, left main ostium naturally is very difficult to go for slow dilatation. You want to complete the job fast. That's the whole thing.
Thank you,
That
Dr.
was a
Sabri.
very bitter experience I had.
We have time problem. So now I'll request Dr. Mantri to present the final case and Dr. Karthik to kindly moderate the case. Dr. Mantri, please.
Yeah, Dr. Mantri.
I have forgotten the pen drive in the hospital in hurry, so I will not be able to present my case.
No,
Yeah, Mantriji,
no,
sorry for
Mantriji,
that.
Mantriji was busy. That's the thing.
No, I had a very good case. In fact, one of our orthopedic consultant had long calcific RCA lesion, where we
That's
first used rota, then we used cutting balloon, and then we used DEP.
So what was the take-home message from that case? You please tell us that. Then
Yeah,
we'll have a discussion.
Yeah. Take-home message is that then long calcific lesion, multiple nodules. So just putting stent may not solve the problem. We prepared the bed very well, and then we did OCT again. There was no significant dissection, flow limiting dissection, and we could finish the case with aperta and DEB. And the patient, the doctor is doing well 5 months after the procedure, asymptomatic. So that case I wanted to present, which I did with aperta and rota cut and DEB.
Okay. So, Magesh sir, and probably even Sahu, Sanjeev, I can't see him. How often or what is your experience in calcific nodule with aperta? Because I had a lot of cases to show, but anyway, there was lack of time, probably some other time we can have. And there is a lot of interest, especially calcific.
I wanted to ask you.
What is your experience with that?
Well, I have no experience on aperta and nodules. Let me be very frank.
So in my experience, it doesn't modify the calcific nodule. It cuts the vessel, creates cut at the shoulder between the nodule and the calcium plate. But that also achieves good expansion, stent expansion.
Very good.
Dr. Karthik, your views on DCB in this long calcified lesion? That's a question repeatedly being asked.
Yeah, especially if you got a calcific lesion, after you do all atherectomy and cutting balloon and you're not still able to expand it, I think the best thing is to put a DCB and come out.
Yeah.
Don't put stents there.
Yeah.
Never put stents in an unexpanded calcific lesion.
So the question is, will the drug reach the media in a calcified lesion?
Yes, if you have
Like
created cuts in the calcium, it will reach. It will reach. Otherwise, it may not reach.
What I was telling was earlier, you do imaging. It's very important, especially when you're using a DCB. After you prepare the lesion, you do a imaging and see for expansion and some cuts. And if it made good cuts, then DCB works very well. The drug penetrates, and for the calcific lesion, if there are good cuts, I think it works well.
So one more question from the audience. The take of the expert panel on use of imaging after a DCB has been deployed. Let's start with Dr. Sanjeev.
Imaging after putting a DCB is not mandatory for me, as long as I find there is no flow limiting dissections. I can just leave it like that. Before using a DCB, yes, definitely. But after using a DCB, as long as I have a TIMI3 flow, it's an optional.
Probably the question was aimed at saying that by using an imaging after the DCB, are you going to wipe away or destroy the drug coating or anything? That could be the reason why the question.
Yeah, I have cases
Not
of
necessarily. Basically, what do you find? I mean, you are going to find dissections
We're
only.
not finding anything.
Yeah.
Bypassing an OCT catheter or an IVUS catheter, is it detrimental to the drug coating that you're given? It's a question.
Not really.
I don't think
Dr.
so.
Mantri?
Yeah, not really. I have experience of few cases, and we can see the drug particle by OCT. And in previal stent, what we have seen is that sometimes there is a thick layer of drug which can be visible. Sometimes this is confused as somebody has put a stent, but as far as the drug which has entered the media, it cannot be washed away by
Dr. Shelvamani?
doing
See,
imaging.
actually, role of imaging in DEB is, as Sanjeev Rai said, before putting DEB, it is very, very important.
Yeah.
After putting a DEB, if you have probably type C dissection, probably type A and type B, you can leave it, it is good for DEB. Type C means if there is a extra vessel contrast staining, that is the place where you do imaging to make out whether it is an intimal dissection reducing the flow or not. So there, that is the role of imaging at type C dissection if you have.
Dr.
Apart
Raghu?
from that, there is no other role for imaging
I
post
think-
DEB. But there is nothing wrong in putting a OCT or IVUS after you put a DEB, because many times even we put a balloon and kiss even after a DEB, nothing happens. I think that is the routine practice we do.
Dr. Raghu?
Yeah, I think we can do imaging after DEB. No problem, no hesitation.
Dr. Parikh, are we audible? No. No, your voice is still cracking. I'm not able to hear you.
Ash,
Karthik, final comments?
yeah, routinely I don't use imaging after a DEB. Only as Salomon said, if there's a dissection when you want to confirm whether to put a stent or not, then you do imaging. And doing an imaging doesn't alter that status at all. In fact, as for bifurcation lesions, we do the depth and pull back the balloon, and again we inflate and do a kissing balloon with the same depth. So I don't think there is any problem with putting imaging catheter.
Fabulous. Now, there's just one correction. DEB is not the correct word. DCB is the correct word, although we are all using it interchangeably. The new terminology is, the accepted terminology is DCB. Any comments from anybody regarding whatever we spoke so far?
I want to ask from the panel, what should be size of your aperta balloon compared to vessel size when we are going for high pressure? And especially in context for eccentric calcification and calcified nodule. Do we undersize it? Do we take 1:1?
Okay, let's start from Dr. Sanjeev again.
See, calcified nodule, it all depends on, once you have imaged, obviously you have found a calcified nodule there. So it depends on the arc of the plate. So if the arc of the plate is, let's say 270, you can safely go for a DCB of any cutting balloon of 0.9:1 ratio and do it gently. But if the arc is less than 90 degrees, be very cautious, because what you are going to do, your blades is going to injure the contralateral wall, which is not calcified, and it is going to perforate and dissect, because your blade, the calcified nodule is going to push the blade on the contralateral wall. So
Absolutely.
be cautious about that.
Dr. Mantri, you have views.
Pardon?
You have views on the same topic.
Yeah, I asked the question,
Please,
but
I will tell
You
I
are-
will take 0.25 size smaller balloon if I need to go high pressure.
Perfect.
And if there is a complete ring of calcium, then I will I will measure the calcium ring and go 1:1 based on the inside of the ring diameter. And then I can go high pressure.
Dr. Shelvamani?
No, rightly Sanjeev and Mantri are saying the same thing. You take the help of imaging, look at the block distribution. If it is circumferential calcium, take 1:1. If it is eccentric calcium, look at the vessel opposite to the calcium. If it is a normal vessel, if you can see the media, always undersized. Don't chase it, you will have perforation.
Fabulous.
Very
Dr.
simple.
Karthik?
So look into that and decide.
I wanted to ask Salomani whether he was referring to eruptive nodule or a calcific nodule using
Any
aperta.
nodule, how you decide whether it is a breakable nodule or not is you
No,
put a
eruptive
balloon.
nodule is already broken.
Eruptive
Eruptive nodule is already
nodule
broken. So you
heals
can
very
go ahead.
easily.
No, what we
Yeah,
are saying
no,
is
no, no.
compressibility. It
Calcific
is,
nodule, I have not used aperta and calcific nodule. I just wanted to know your experience, Alomani.
see, actually, calcific nodule is the name for eruptive nodule. Nodular calcium is the name for non-eruptive nodule. Okay, it is like that. See, calcific nodule is seen in acutamides, like where it is erupted, you call it as calcific
I mean,
nodule. Many times it is compressible. You put a balloon and dilate. If it is compressible, good. If it is not compressible, not yielding, then you call it, it is a resistant nodule, probably, or nodular calcium, where we have separate technology. Like probably you will have to use an orbital there, or you will have to use an IBL or high pressure balloon. But whatever you do, you take an imaging. Like for example, if it's a non-compressible nodule, if the lumen area is very good, and if the vessel opposite your nodule is normal, that is, it has 3 layers, like media is well seen, then don't take 1:1. You will have problems. You can have a rupture. So in such cases, probably always undersize or accept whatever you have got if it is an adequate lumen size and come out. That is the safest way to approach.
Dr. Raghu, your approach?
I think I agree with Sanjeev and Salomani that we need to see the balloon, have a feel with the balloon. If you don't have the IVAS and all that, feel with the balloon. If it is not dilating, don't take 1:1. If it is one good dilatation of the balloon, take a 1:1. That's what I do.
Okay. Handing over back to Dr. Gauravi Kumari to conclude the session, please.
Thanks a lot, sir. Okay. So on behalf of Veiva Scientific team, I thank a lot to our moderator, N.K. Mahesh sir, as well as all our esteemed panelists and speakers. And a big thank you to all the participants as well for contributing to such an enlightening session. And dear audience, on behalf of Veiva Scientific team, we wish you all best for your future endeavors, and we look forward to seeing you again in the future sessions.
So Dr.
Have a great evening ahead.
Gauravi, what is your take-home message for Veiva from this talk?
Sir, I don't think I would be the right person to
You have
answer
to have
that.
a thing. Please start introducing DCB into the market. That is the future, and you guys are not bothered. Fast.
Okay, sir.
Every minute. The whole discussion, so 30% of the discussion was on DCB. Please
Sure,
understand.
sir. We will take
That's
this
where the world
message
is
to the
going.
team.
Thank you, guys. Thank you all.
Thank
Have
you.
a nice night.
Thank you.
Bye-bye.
Thanks a lot,
Bye.
sir. Thank you. Thank you, everyone.